So we pick up in our respiratory unit, part 2 of the unit, taking a look at this relationship between capillaries that are moving through all of our lungs and interfacing with our alveoli, and how we have gas exchange of oxygen into the red blood cells and carbon dioxide out of the blood and the red blood cells. We see an alveolar epithelium. So remembering that epithelia coat areas that are covered that interact with the external environment. We see a pulmonary endothelium. So this is deeper in the lungs, and a fused basement membrane. So we have this connective tissue that's tying together this epithelial tissue and endothelial tissue to help us keep our capillary beds tied onto our alveoli. In respiration, then, we take a look at the respiratory system. We have pulmonary ventilation, or breathing air into and out of the lungs. We have external respiration, which would be oxygen and carbon dioxide exchange between the lungs and blood. And then we have transport of oxygen and carbon dioxide in the blood to then move into internal respiration, where oxygen and carbon dioxide are exchanged between systemic blood vessels and tissues. So we have a handoff from the respiratory system to the circulatory system in relation to oxygen and carbon dioxide. Pulmonary ventilation, we're going to look at a few topics. Boyle's law, which is a law that's focused on the idea that gas pressure is inversely related to volume. So more volume, less pressure. Less volume, more pressure. Inspiration, how we bring air into the lungs. We're doing that with muscles, changes in volume and changes in pressure. How we're expiring air, we're again using our muscles. We're going through volume changes of the thorax and the lungs, and pressure changes as well. Then lung pressures, we'll take a look at intrapulmonary pressure. So this is the pressure of the lung. Intrapleural pressure, so the pressure that's in the pleura that surround the lungs, this serous membrane. And then atmospheric pressure, which is the pressure that is outside of our bodies all of the time, and then interfacing with gases that are going to come into our lungs and leave them. Some physical factors affecting pulmonary ventilation are airway resistance, alveolar surface tension, and lung compliance. We need a good open airway, we need alveoli that don't stick to each other, and we need lungs that are more elastic and able to comfortably move oxygen in and out of themselves. So pulmonary ventilation, then, we see that when we breathe in, our diaphragm is going to lower, our rib cage will raise up. When we breathe out, when we expire, our diaphragm comes up, our ribs close in, and so what's happening is we're going through a larger volume to a smaller volume, larger volume, smaller volume, less pressure, more pressure, less pressure, more pressure. And that is overcoming or accepting air that needs to come into the lungs or leave the lungs. Boyle's law says that gas pressure is inversely related to volume. So within the concept of pulmonary ventilation, we want to take a look at how volume is changing and how pressure relates to that. So what we see is that if we have increased volume, we have decreased pressure. Gas pressure is inversely related to volume. Pressure is going to be opposite of whatever volume does. Volume is going to be opposite of whatever pressure does. Then if we see that we have decreased volume, the opposite of that in pressure is increased pressure. So Boyle's law is what helps us understand why more volume equals less pressure and less volume equals more pressure. And this is a very key component of pulmonary ventilation. We see, if we relate Boyle's law to what happens in hot air balloons, as we ascend in elevation, the atmospheric pressure drops. So if we have a drop in pressure, we're going to have an increase in volume. So the gas that was in the balloon closer to the ground, say at 15,000 feet, once we've ascended to 43,000 feet, the gas that was within the balloon has much less pressure acting on it, so it expands quite a bit. So the higher we go, the more we have an expansion of volumes that are constrained. And when we have an increase in volume, we have a decrease in pressure. If we think about this, if we were in an airplane and our cabins were not pressurized when we ascend to, say, 43,000 feet, if we weren't in a pressurized cabin that kept us at about the elevation pressure-wise that we left off at, gas that would be trapped within us would expand as we would ascend. And this is a big part of why cabins are in aircraft are pressurized. The other reason why, of course, is that with a pressurized cabin, we don't have to worry about a lack of pressure to move oxygen into our lungs. We're able to breathe without the assistance of external oxygen, which is why in an airplane, when they say, if we lose cabin pressure, these oxygen masks will drop from the ceiling, and the first thing you're going to want to do is start breathing oxygen, because there will be a lot of other things happening, like gases in the body expanding, lots of pain, eardrums popping. And so the main thing, though, is to maintain consciousness by taking in oxygen so you can help other people around you. So from a flatulence perspective, thank goodness for pressurized cabins in airplanes, right? Pulmonary ventilation, then, these ideas of the expansion of the rib cage to allow for easier inspiration, a larger volume in the rib cage, creating a lower pressure that allows air to come into the lungs. So we see external intercostals contracting, the ribs rise and the sternum flares out, and the diaphragm contracts and moves inferiorly, increasing volume in the thorax, which decreases pressure and allows the pressure from the atmosphere, the oxygen, to push into the lungs. When we expire, the opposite happens. The external intercostals relax, and the ribs in the sternum move forward. The diaphragm relaxes and moves superiorly, so this whole compartment compresses in the thorax. The lower volume creates a higher pressure, and we expire the air that was in the lungs. So what happens to lung volume during inspiration? Think about that for a second and answer for yourself. Lung volume during inspiration is going to increase. And then what happens to our intrapulmonary pressure during this inspiration? Take a second and answer that. The intrapulmonary pressure is going to decrease. So we have an increase in volume. We see the opposite in pressure, a decrease in pressure. What happens to the volume of the pleural space during inspiration? So the pleural space then is going to be the space in between the lungs and the wall of the chest. And so what we would think about within this is, in the pleural space, this intrapleural pressure, we're going to see a negative pressure occurring that's lower than our intrapulmonary pressure, so that the pleural space allows for adhesion of the lungs to the thorax so that the lungs don't deflate. During expiration, what happens to lung volume? We see that lung volume in expiration is going to decrease, and so intrapulmonary pressure is going to increase, and we're able to expire the air. The volume of the pleural space during expiration is still going to remain negative compared to the lungs, so that the lungs don't collapse while we're expiring. Some ideas about lung pressures. The pressure at 1 atmosphere is 760 millimeters of mercury. 760 millimeters of mercury would move up a tube marked with impressions for millimeters, and that would say that we're at 1 atmosphere. So when we think about this being a 1 atmosphere, 760 millimeters of mercury being a sort of a baseline measurement, we see that pressure wants to come into the lungs. It can come in if the lung pressure is lower, and notice that this intrapleural pressure is always a little bit lower than the intrapulmonary pressure. And the reason for that is that then we're able to comfortably adhere the visceral layer of the pleura to the parietal layer of the lungs. And so then we have a slightly lower pressure in this intrapleural space that attracts the lungs to it and helps the lungs stay inflated at all points in time. This negative pleural pressure, meaning that it has less pressure or it's less than the pressure in the lungs, is if we think of each lung as a giant gas bubble composed of many tiny gas bubbles, then asking ourselves what would happen to the lungs if the pressure in the pleural space surrounding the lungs was greater than the pressure within the lungs. So what we're saying is that the surroundings of the lungs, the coverings of the lungs being the pleura, if that pressure within the pleural space was greater than the pressure that was within the lungs, then we would have a collapse of the lungs. So we've always got to have our pleural pressure be lower than our pulmonary pressure. Pleural pressure is always negative due to the opposing forces that we'll see in terms of collapsing forces like elastic recoil of the lung and surface tension help maintain negative pressure. And then the expansive force or the elasticity of the chest wall, these two components pulling against each other create a negative pressure within the intrapleural space. Surface tension within alveoli tends to collapse the alveoli, and in this, if we collapse the alveoli, we collapse the lungs. So the lung is stretchy, and that means that there's an elastic recoil force that tends to collapse the lungs just by their nature. If we think about the architecture of our chest wall, the ribs are compressed by the intercostal muscles. The natural tendency is to expand. And so in the end, what we see is that we have the pressure of the pleura is less than the pressure of the lungs, which is approximately the pressure of the atmospheric pressure. So our variance here in expansion and contraction of the lungs is going to allow for inflow of air or outflow, depending on that pressure relationship. But the pleura always remain negative in pressure related to whatever the pulmonary pressure is in the lungs. When we have problems with pressure between the intrapleural cavity and the pulmonary cavity, we can have issues like atelectasis. This example of atelectasis is in asthma, where here we can see in the left lung there's a lot of filling of the lung with mucus that can cause a partial collapse of the lung or a plugging of the lung. Atelectasis is an issue where we can have a collapsed lung or a lung that just isn't able to bring oxygen in because of some kind of an occlusion. Here we can see that in this instance of atelectasis, that the lung has collapsed inside the cavity, and this was due to hemothorax, so blood that would get in between the parietal portion of the pleura and the visceral portion, and having that pressure change would decompress the lung. And here's the heart and its pericardium. The ribs are retracted here to give you a sense of where this lung would have normally filled this entire cavity. Some physical factors affecting pulmonary ventilation. We must overcome 3 factors during pulmonary ventilation. We have to overcome airway resistance, alveolar surface tension, and lung compliance. So within airway resistance, we see that airflow in the respiratory tract, in larger airways, we'll see a turbulent flow. In medium airways, we'll see a disturbed laminar flow. And a laminar flow is what we see in smaller airways that's sort of laminated, almost like laminated sheets of wood. Airflow in the respiratory tract, as we get into smaller airways and we start seeing more friction as we get smaller, we can have resistance to airflow. The alveolar surface tension issue comes into play because water molecules are attracted to other water molecules at the air-water interface within the lungs. And the surface tension then is going to resist any force that tends to increase surface area of the H2O. What we're looking at here is the surface tension of water, because of its attraction to itself, will resist any increase in surface area because of the attraction of these water molecules to each other. To combat this, our lungs have type 2 cells within them that release surfactant, which is a detergent-like lipid and protein complex, so it's very slick, almost like dish soap, and it's produced by type 2 alveolar cells and reduces surface tension of alveolar fluid, which discourages alveolar collapse when we exhale. So in an alveolus with no surfactant, we have this water attraction that will try to close an alveolus when we expire air. But with surfactant, we have this layer of detergent-like material in the surfactant that helps stop the attraction between water molecules so that we can go ahead and exhale air and then still have these alveoli re-expand. Lung compliance then is the concept of how easy does the lung expand, and this is normally high due to distensibility of lung tissue. Normal lung is very elastic. Alveolar surface tension is kept low by surfactant. So just saying that lung compliance, or the ease with which the lungs can expand and contract and expand, is accommodated by the types of tissues that are at play and the components that they release, like surfactant. Here, as we see the distensibility of the lung tissue and then the surfactant resisting collapse, we can see how that allows us to have normal inhalation and exhalation. Lung compliance can be diminished by non-elastic scar tissue or fibrosis, damage within the lungs, reduced production of surfactant when alveoli stick together, and decreased flexibility of the thoracic cage. So over time or through damage, broken ribs, different things, the flexibility of the thoracic cage can be compromised, and all of these items will lead to diminished lung compliance. Here we can see normal alveolar sacs expanding and contracting, bronchitis and itis, a swelling or congestion of the bronchioles, and emphysema, where the alveoli have broken down and we've lost surface area that doesn't allow us to have as efficient gas exchange. Exchange of gases at lungs and tissues. We have external respiration, which is exchange at the lungs, internal respiration, which is exchange at the tissues, and we must first consider the physical properties of gases that are at play within these tissues before we can understand how gas is actually exchanged. So we'll take a look at Dalton's law, Henry's law, and Fick's law. Dalton's law of partial pressures says that the total pressure exerted by a mixture of gases is the sum of the pressures exerted by each gas. So just saying that, say, these blue molecules are oxygen, the red are carbon dioxide, and the green are nitrogen, that the total pressure that's being exerted in this box is the sum of each of these different gases that is in the box. Partial pressure of each gas is directly proportional to its percentage in the mixture. So just saying that the way we arrive at the partial pressure of the gas is based on the percentage of this gas's existence in its environment. We'll see percentages of, say, 20% oxygen and 70% nitrogen, for instance. That would just say that the partial pressure that those gases are exerting is proportionate to the amount that they exist in the mixture. Pretty common sense part of the law. Dalton's law broken out then would say that, for instance, atmospheric pressure is about 21% of the pressure of oxygen, 0.04% of the pressure of carbon dioxide, 78% nitrogen, and then a variable percentage of water vapor. And all of these partial pressures equal up to 1 atmospheric pressure, or a percentage of atmospheric pressure. So say, for instance, that we have the partial pressure of oxygen at 760 millimeters of mercury, or 1 atmosphere, and then going from the percentage of 21% of oxygen in the total times the 760 millimeters of mercury or 1 atmosphere of pressure in an ATM. That would say that at sea level, we would have 160 millimeters of mercury of pressure that oxygen is applying to the overall atmospheric pressure. When we go up in elevation, we see that pressure, partial pressure of oxygen, drop to 132 millimeters. And if we were on the summit of Mount Everest, we would see that pressure drop to 53 millimeters of mercury. So you can see why some sports players that start at sea level may need a day or two to acclimatize to Denver, and they need to release more erythropoietin, put more red blood cells into the mix, and start moving more oxygen because there's less of it coming into the lungs at lower pressure. Whereas then at Mount Everest, we know that people need to be on extra oxygen to be able to summit or stay in that area very long, because the partial pressure of oxygen is so low that our bodies are not quite able to adapt to that. Even with erythropoietin release, we need supplemental oxygen to be able to live in those areas or operate in those areas. Another image of this, that if we see the partial pressure gradient for oxygen at sea level at 1 atmosphere of 760 millimeters of mercury, we would say that oxygen is at 104 millimeters of mercury. In venous blood that's deoxygenated, there's still oxygen in it, but it may only be at 40 millimeters of mercury. When we go ahead and tie oxygen on from the alveolus that we've been bringing new oxygenated air into, we transfer that into the hemoglobin, and we see our arterial blood O2 go up to 96 millimeters of mercury. So a transition that we would see happen, that we realize that we're not bringing in that total pressure, we're bringing in a partial amount of that pressure, but its pressure in the alveolus is greater than the pressure in the venous blood. That pressure gradient helps move oxygen into the blood, and then that gives us the oxygen we need to feed our tissues. If we have a rapid change from sea level with no acclimatization, then we could see oxygen drop to 82 millimeters of mercury. Our overall atmospheric pressure has dropped to 630 millimeters of mercury. So our deoxygenated blood, our venous blood, could be at 35, and then when we go ahead and push more of this oxygen in, because there is still this gradient that exists, however, our oxygen within the arterial blood could only be, say, at 69 millimeters of mercury, which is a deficit compared to what we would see at 96 millimeters of mercury. So we're going to feel maybe more tired, a little bit, have some headaches, have some different issues that just have to do with adapting to a lower amount of pressure as we've increased in elevation. And that's happening directly in our blood. Henry's law then says that the quantity of gas that dissolves in liquid is proportional to the partial pressure of gas that's over the liquid. Also taking a look at the solubility of the gas that we're looking at, and those items then would say, for instance, that carbon dioxide is 20 more times soluble in water than oxygen. So it has a higher solubility in liquid. Very little, in contrast, very little nitrogen dissolves in water. Its solubility in liquid is not as high as oxygen or carbon dioxide. Henry's law would say then that an increase in the pressure of gas over liquid leads to an increased solubility of the gas. So effectively, we're creating more pressure that's pushing more gas into liquid. In a soda bottle, for instance, we've seen this, that gases are held under pressure, and when the cap is removed, we see a drop in pressure, which creates a drop of gas in solution, and we see gas escaping as bubbles. So this is directly related to Henry's law that would say once the pressure is removed, then the affinity for those gases to be in fluid is released, and those gases can escape. We take a look at this when we're considering scuba diving and we're breathing pressurized air. that has oxygen and nitrogen in it because it's not pure oxygen. And so what we see is that the nitrogen that's being inhaled in this pressurized air will contain approximately 78% nitrogen, which has little effect in our atmospheric air. So low solubility coefficient, meaning that the gas doesn't easily go into liquid, which means that little dissolves in plasma as we naturally inhale nitrogen. But when we're breathing pressurized air, like within scuba diving, the total pressure increases, which increases the partial pressure of nitrogen. And so that allows nitrogen to dissolve in plasma, which can cause giddiness or intoxication, sometimes referred to as rapture of the deep. And if the diver is brought to the surface slowly, this nitrogen can leave the body via the lungs gradually. But if the diver is brought to the surface quickly, the nitrogen bubbles out of blood and into tissues, just like opening up a soda bottle. This causes joint pain, dizziness, unconsciousness, and what's referred to as the bends. We can also recompress people in a hyperbaric oxygen chamber and then slowly decompress so that nitrogen can be expired through the lungs. Another way to simulate a more gradual rise to the surface is to use a hyperbaric chamber. So Henry's law, we have a lot of oxygen in the alveolus and not a lot in our venous blood. So we have a concentration gradient, and we have this ability to move through water, and oxygen moves through that and is able to move into the capillary blood flow to then go ahead and oxygenate the blood through its connection with hemoglobin. External respiration then is diffusion of gases between lungs and blood, and this is influenced by structural characteristics of the respiratory membrane, as well as partial pressure gradients and gas solubilities. And what we see is that in the respiratory membrane, it's only 0.5 to 1 micrometer thick, and it has a large total surface area, about 40 times the surface area of skin. So if we could take all of these membranes in one set of lungs, they could be laid out on the floor of a 400 square foot room. So a tremendous amount of surface area within each of our lungs, completely set up to allow for this exchange of oxygen and carbon dioxide into our bloodstream from the lungs, from the alveoli. We see the alveolar epithelium, the pulmonary endothelium, and the fused basement membrane again, these structures that connect up with the capillaries that connect to the lungs. In external respiration then, here we're in an alveolus in the lungs, and we would see that carbon dioxide at a higher pressure would move out of the venous blood flow in the capillaries and back out into the alveolus, where the carbon dioxide pressure is lower in air that has been inhaled. In this inhaled air in the alveolus, the pressure is higher at 100 millimeters of mercury, whereas in the venous blood flow in the capillaries it's lower, and so naturally we move down that gradient, and then we have this escape on the other side that allows us to have lower carbon dioxide and higher oxygen in our arterial blood flow. Fick's law of diffusion would say that the rate of diffusion is proportional to the surface area, the diffusion coefficient, so each gas has its own coefficient or a known quantity or percentage that it's known to diffuse through other substances, and then a change in pressure or the pressure gradient divided by the thickness of the respiratory membrane. So effectively what Fick's law says is that if we have more surface area and we have a diffusion coefficient that is favorable with a change in pressure that's high enough and a respiratory membrane that's thin enough, we're going to have a high rate of diffusion. And so that's why we see carbon dioxide with its diffusion coefficient being so much greater than that of oxygen, and then moving through the same membrane at its own relevant pressures we see that we have a rate of diffusion for carbon dioxide that is pretty readily available. And oxygen has its own components to it that say that its diffusion coefficient, change in pressure, the thickness of the respiratory membrane, and that overall surface area allow for a favorable diffusion of oxygen as well. So oxygen in the blood is moving mostly on oxygenated hemoglobin, on hemoglobin that has oxygen on it, and that's about 98.5% of the way blood oxygen is carried in the blood. The other 1.5% of oxygen in the blood is carried in the plasma. So not a lot of oxygen diffusing into the plasma, having to do with that diffusion coefficient. So we see that oxygen joins up with hemoglobin, pushes off hydrogen, and creates some acidity within the blood. And then we have oxygenated hemoglobin that's ready to go to the cells. When we take a look at carbon dioxide in the blood, we see that it's tied on mostly to bicarbonate. About 95% of it is traveling with bicarbonate. And then the other portion of it in the plasma is around 5% that is diffusing into the plasma. So water plus carbon dioxide equals carbonic acid. And carbonic acid will then go ahead and adjust to bicarbonate and hydrogen. As we take a look at a little bit of a simplified version of oxygen coming into our system from an alveolus and then carbon dioxide going back into an alveolus for exhalation, we start at the alveolus in the lungs where we see oxygen is coming into the red blood cell, and hemoglobin is attached to, has a hydrogen unit attached to it. When oxygen comes into the red blood cell as it's come across the alveolus into the capillary bed, then it will effectively push off the hydrogen proton and attach to hemoglobin. Now, the first oxygen that attaches to one of the hemoglobin units will be the hardest oxygen to attach, and every oxygen after that will have a little bit easier time attaching to the hemoglobin until the hemoglobin has all four of its iron ions that are taken up with oxygen. So meanwhile, we've also pushed off this hydrogen, which is making our blood a little bit more acidic, and in the capillary bed then it's attaching to bicarbonate, HCO3, and transitioning into carbonic acid, H2CO3, which then will go ahead and dissociate into water and carbon dioxide, which we will then expire or exhale out of our alveolus. When we take a look at this then from the cell's perspective, if we're in the tissue, and from the cell then to the red blood cells in these capillary beds that we have, we're releasing carbon dioxide, and there's also water within the mix within the red blood cells that then is combining with carbon dioxide to form carbonic acid that then dissociates into hydrogen protons and bicarbonate, and then those hydrogen protons will go ahead and help to move oxygen off of hemoglobin, and then we'll see that hemoglobin and hydrogen bond and oxygen is then available to go ahead and move out of the red blood cells off of the hemoglobin unit into the cell to be available for any of the cellular respiration processes that need to occur. When we think about oxygen binding to hemoglobin, we have to look at a few components that impact this binding. We'll be interested in the pressure of oxygen, the pH that is in the bloodstream. We need to maintain a pH in the blood of 7.35 to 7.45, so a very finite range of acid-base relationship in the blood. Then we need to take a look at temperature that's affecting the oxygen binding to hemoglobin, as well as the partial pressure of carbon dioxide, a component that we look at in conjunction with helping oxygen leave hemoglobin, which is BPG, or bisphosphoglyceric acid. We also may see BPG interplaced with another component called DPG, or diphosphoglyceric acid, or diphosphoglycerate. Either of these components, BPG or DPG, can assist in helping oxygen leave hemoglobin. So we'll take a look at how each of these components play into oxygen binding to hemoglobin. In one of the charts that we see related to this, the oxygen hemoglobin dissociation curve. So what we're taking a look at is oxygen saturation on hemoglobin, and then the pressure that's related that over a span of pressure. So over a certain span of pressure, how much oxygen gets attached on to hemoglobin. So we can see that at a relatively low pressure, at about 20 millimeters of mercury, we would be at about 40% saturation of oxygen on hemoglobin. But then when we go to 40 millimeters of mercury of our partial pressure of oxygen, we're at almost 75% oxygen saturation. So this curve is just showing that the more pressure we have available, the partial pressure of oxygen, the greater saturation of hemoglobin that we'll have. And so what we're interested in here is more oxygen saturation, more oxygen available for the cells within the body. In red blood cells, we see that water and carbon dioxide are constantly moving along and coming together with carbonic anhydrase to form carbonic acid. And then we also see hydrogen pulling off of carbonic acid and giving us bicarbonate. And whenever we see these indicators, we're always in a back and forth type of situation in this equation. So this transfer from bicarbonate to water, from bicarbonate and hydrogen to carbon dioxide and water, the carbonic acid connection, this is what's typically referred to as a buffer system. So taking acid out of the bloodstream, this hydrogen, and binding it to carbonic acid, and then transitioning that to carbon dioxide and water, is a change that is consistently going back and forth within the bloodstream to keep our pH regulated between that 7.35 and 7.45 pH level. If we see an increase in carbon dioxide, we'll see an increase in hydrogen, which will lower pH, and lower pH means higher acidity. The effect of carbon dioxide and hydrogen on hemoglobin saturation would show that if this light purple line is our normal CO2 or hydrogen levels within the blood, we could expect a hemoglobin saturation of oxygen at this rate. If we have lower carbon dioxide or lower hydrogen, we see much higher saturation of hemoglobin with oxygen. However, if we have increased levels of carbon dioxide or hydrogen, we see much lower saturation of hemoglobin. And that makes sense because we know that carbon dioxide replaces oxygen very readily. And so if we're in competition with carbon dioxide for oxygen space, carbon dioxide will win. And so it makes sense that if we have high levels of CO2, we have less saturation of oxygen on hemoglobin. If we have low levels of CO2, we have higher saturation of hemoglobin with oxygen. When we look at the effect of body temperature on hemoglobin saturation, we see that here in this purple line we have normal body temperature, so 38 degrees Celsius. When we have a shift within our body temperature, if we get warmer, we see that we have less saturation of hemoglobin. So we see this happen when in exercise, for instance. and we're offloading oxygen from hemoglobin faster than it can sometimes reload it, and in part that ties in with a higher temperature that we're creating within the body. When we have lower temperatures, we load hemoglobin with oxygen much faster, and so we see a correlation here in temperature between lower temperatures giving us better hemoglobin saturation with oxygen, and higher temperatures giving us poorer saturation of hemoglobin with oxygen. In contrast between fetal and maternal hemoglobin saturation, we see that the hemoglobin that is in the fetus has an ability to saturate with oxygen much faster than at lower pressures than maternal blood. And this makes sense because a fetus in development going through rapid development is going to need to capitalize on oxygen stores that are available in a way that is much more efficient. So in the tissues, we have water plus carbon dioxide that goes to carbonic acid that then dissociates to hydrogen and bicarbonate, that then pushes off these hydrogen protons that will help displace oxygen from hemoglobin, that will then allow oxygen to go into the tissues of cells, and this is all happening in the capillary bed. Then in the lungs, we have a large amount of oxygen that comes in, and we have our hemoglobin with hydrogen on it. Oxygen displaces that hydrogen and on hemoglobin, so our blood becomes somewhat more acidic until hemoglobin meets up with bicarbonate, moves into carbonic acid, and then dissociates into CO2 and water, where we can expire CO2 and respirate that out. The control of respiration, then, how we're controlling all of this from a neural level, is that we have nervous control via respiratory centers in the brainstem, part of the reticular formation in the medulla and pons, and we have a ventral respiratory group, the VRG, which have inspiratory neurons and expiratory neurons, so neurons committed to bringing air in and pushing air out, and these cycle on and off as needed, which gives us our cyclical breathing pattern. We have a dorsal respiratory group, so dorsal just being posterior. We see that this integrates information from peripheral stretch and chemoreceptors. So as the lungs stretch, we're getting information from that. And then as we have chemoreceptors that are picking up acid levels or carbon dioxide levels, we're sensing that. And this will offer input into the VRG, the ventral respiratory group. The pontine respiratory center, or pons, which smooths the transition between inspiration and expiration, giving us smoother breathing patterns, and modifies breathing rhythm during vocalization, sleep, and exercise. And it also has an input into the VRG. And these centers, we can see here we are in the brain, and we're down near pons and medulla oblongata, where we see the pontine respiratory centers in their location, the ventral respiratory group, and then the dorsal respiratory group. So these are clusters of neurons that are helping us refine our breathing and sending messages into the respiratory diaphragm and the intercostal muscles, the external intercostal muscles. So higher brain centers, the cerebral cortex, we have voluntary control over our breathing. We know that we can go ahead and take over voluntary control of breathing. This will run through the respiratory centers in the medulla and pons. We have peripheral chemoreceptors that sense low oxygen, high carbon dioxide, high acidity. Central chemoreceptors that are also sensing carbon dioxide and high acidity. These receptors in muscles and joints that are also giving us information. We have irritant receptors that can assist with noting irritation within these lung centers and from the trachea, and stretch receptors in the lungs that can also assist with knowing how our breathing rate is going. Other receptors like pain and emotional stimuli acting through the hypothalamus can elicit different breathing responses as well. So, for instance, if we see arterial pressure of carbon dioxide go up, then we have increased pressure of carbon dioxide, increased hydrogen, decreased pH in the brain's extracellular fluid that then allows for central chemoreceptors in the medulla to respond to hydrogen in the brain extracellular fluid and mediate 70% of the carbon dioxide response. The other 30% of the carbon dioxide response is handled by peripheral chemoreceptors in the carotid artery and aortic bodies. So these in these massive arteries, we also have chemoreceptors that are mediating the other 30% of this carbon dioxide response. So these are afferent impulses. They're traveling to the brain, and they run through the medullary respiratory centers that then run respiratory muscles and ventilation. So more carbon dioxide is exhaled. And then we have arterial carbon dioxide and pH return to normal. So we go from this sensory component to an afferent feed to the brain to an efferent impulse that helps adjust us in our musculature to ventilate out carbon dioxide and return carbon dioxide and acid levels to normal. Sensory input from the respiratory system arrives in the cerebral cortex and allows for voluntary regulation of the system. The hypothalamus is in charge of receiving sensory input related to emotions and pain, which elicit changes in respiratory rhythm like we would expect to see within a fight or flight reflex. The inflation reflex, or the Herring-Breuer reflex, is sensory input that is received within the medulla of the inspiratory centers of the brain that would say that we're only supposed to be able to inflate to a certain amount before our inspiratory center would be inhibited so that inflation has ceased, so that there isn't damage done to the lungs through overinflation. Chemical stimuli of the system would say that we're very sensitive to levels of oxygen, carbon dioxide, and hydrogen in arterial blood. So central chemoreceptors in the brainstem that monitor hydrogen concentrations and or carbon dioxide, as well as peripheral chemoreceptors in aortic arch and common carotids that we discussed previously that also monitor hydrogen, carbon dioxide, and oxygen in the blood. Monitoring of CO2 levels would say that normal CO2 pressure in arterial blood is 40 millimeters of mercury. So an increase in CO2 in arterial blood would increase hydrogen in arterial blood, and our system is very sensitive to changes in CO2 in large part because of the acidity that's caused through large amounts of CO2 in the blood. In red blood cells then, we again see that water and carbon dioxide with carbonic anhydrase will form carbonic acid, and then carbonic acid can dissociate into hydrogen and bicarbonate as well. So increase in carbon dioxide causes an increase in hydrogen, which causes a decrease in pH or higher acidity. Respiratory responses to acidosis and alkalosis. In acidosis, we have high amounts of hydrogen, so we want to see that hydrogen tied on to bicarbonate to then create carbonic acid and then dissociate into water and carbon dioxide. And so through increased ventilation, we'll see decreased CO2, which will decrease hydrogen or acidity. In alkalosis, we have a small amount of hydrogen that is tied to bicarbonate that then creates carbonic acid and dissociates into water and CO2. So through decreased ventilation, we increase carbon dioxide and then increase hydrogen, which in turn increases acidity and can reverse alkalosis. The monitoring of oxygen levels then through peripheral chemoreceptors are the only receptors sensitive to low partial pressure of oxygen. central chemoreceptors do not respond to changes of the pressure of oxygen. So arterial pressure of oxygen must drop from 100 millimeters of mercury to 60 millimeters of mercury before there will be an increase in ventilation. So what this slide is saying is that our system is much more finely tuned in to the levels of carbon dioxide and hydrogen than it is actually to the levels of oxygen.